this, we have another eminent speaker with us, Dr. Ritu Lokhande. She is a consultant radiologist, FMF certified for NT and NB. She is at Matrix Imaging Center, Pune. She is a lot of things, so I'll just read down the huge retinue of accomplishments that she has. She is the cultural chairman of IMA PCB and was the ex-joint secretary of IMA PCB. She is the founder and ex-secretary of PCM CRA. I'm not elaborating on it because there's a lot of things in her retinue. She is the joint treasurer of SPTA, core member of BMA Banner Medicos Association. She is the national coordinator of Raksha, which is the initiative of IRIA to save the girl child. She is the recipient of SPTA Bhushan in year 2019. She is a recipient of Me Nav Durga Pudhari Award, and highly impressive, she was felicitated by the governor of Maharashtra for Beti Bachao, Beti Padhao scheme. She is a coordinator with Times of India for an initiative of Happy Streets. She is a brand promoter of Lokmat Marathon, Pinkathon ambassador. She is an organizer and styling expert of MediQueen, which is India's first beauty pageant of doctors conducted by the doctors. And she is the jury for the auditions, which is held in Mumbai, in Maharashtra. She is a jury for ALA Mode Fashion Show for Hoteliers Association. Recently was featured in Femina, November issue, which is highly impressive again. Jury for Rap Fashion Icon, which was having a stupendous success. Again, Rap Fashion is Radiology Art Podium. It is again the radiologists at national level, all coming together with multiple talents of their own to showcase a forum for all of them. She believes healthy mind rests in a healthy body, and her magic mantra is to stay fit, stay smiling. She runs marathons, volunteers supports for such events, pursues a passion for cooking, dress designing, which makes her a favorite in the elite society, and she's a known socialite. She is in association with Times of India, has propagated various social events for cancer awareness, arranged a ramp walk for cancer survivors, and is a coordinator for BMA. She has also done skit and interaction of PCMC officials for the Beti Bachao, Beti Padhao. So basically the list is endless, it's huge. So she's a woman of few words, but lets her actions show more. And I'm sure we can understand the amount of commitment she shows towards the society. So looking ahead for your talk, Dr. Ritu, over to you for the talk on PCOS.
Thank you so very much, Avni, for this kind introduction. The best and beautiful things in this world can't be seen or even touched. They must be felt only by heart. Thank you once again for having me here. Thank you, Gomati ma'am. Thank you, Dr. Rijo. Thank you, Varghese ma'am, for inviting me here. Without further ado, let's start with the talk about PCOS. So ma'am, may we have my slide, please? Next slide. PCOD, popularly known as Polycystic Ovarian Disease. There's a lot of, we have talked enough about PCOD. Epidemiology is very, very common. There is hardly any difference between blacks. The 7% females present with irregularity of periods and infertility. Even in this picture, we can see that normal ovary looks smaller and polycystic, that is the whole difference, normal and polycystic ovaries. So my next slide, please. Polycystic ovarian syndrome is a hormonal disorder between 5 to 10% of women in reproductive age group of 15 to 44 years may have PCOD. Most of them come to know about this problem when they are in 20s or 30s, because they really want to get pregnant. That is the time they start thinking about if there's something abnormal with their periods. And actually it can happen during any age after puberty, but until the time we are married, we are not bothered about our periods. It happens with each one of us because we are not bothered about those periods. But once you are married or maybe in 30s, we are bothered about getting pregnant. So we start investigating about the PCOD. Risk of PCOS may be higher if there's a coexisting obesity. It affects many organs of the body. It affects the skin. You must have seen hirsutism, male hair pattern. This is the ultrasound appearance of the polycystic ovary. Next slide, please. Most of the time, there is a presence of menstrual abnormalities and ovulation. There is a 10 millimeter is the criteria. There may be definitions for the criteria, but the bottom line remains they are bigger in size and have multiple cysts. And it's a vicious cycle. There is a chronic anovulation, there may be clinical and biochemical signs. And most importantly, we all should exclude other etiology. There is revised 2003 criteria in which oligo anovulation or clinical and biochemical signs of hypererogenism, polycystic ovaries, and exclusion of other causes of androgenism is considered for PCOS. The diagnostic criteria remain the insulin.
Avani, any issues?
I don't know, ma'am. It got frozen. I thought it was my net, so I was calling Soumya. It is frozen. I'll just call Soumya and find out. 1 second, ma'am.
When I
Yeah. Her net is unstable, I think.
Dr. Ritu, it's better you switch off the video and the audio will be better then.
sorry.
You can switch off, stop the video so that
Okay.
the audio will be better.
Yeah. Is it okay now?
It's okay. It's okay. Carry on.
Yeah.
Carry on.
Yeah. So am I audible?
Yes, Ritu, you're audible. Please continue.
The exact cause of PCOS isn't known till a date. The factors that might play a role include excessive insulin. It's a hormone which is produced in the pancreas that allows cell to use sugar, body's primary energy supply. And if the cells become resistant to the action of insulin, then the blood sugar levels can rise and body might produce excess insulin, might increase the androgen production, and hence may interfere with the ovulation. There's another hypothesis of low-grade inflammation. This is to describe white blood cells production of substance to find infection. Research has shown that women with PCOS have a type of low-grade inflammation that stimulates polycystic ovaries to produce more androgens. Hereditary research suggests that certain genes might be linked to PCOS. There may be actually excess androgen. The ovaries produce an abnormally high level of androgen, resulting in hirsutism and acne. So my next slide. So what are the signs and symptoms? We see very typical phases of PCOS females moving around us, which is very, very common. Often they develop around the first menstrual period during puberty. Sometimes PCOS develops later. Also, the typical signs are regular periods, excessive hair growth. The ovaries will appear polycystic if you do an ultrasound. They are bigger in size. They have the follicles that surround the egg, as well as the ovaries might fail to function regularly. PCOS signs and symptoms are typically more severe if obesity coexists. Next slide, please. Manifestations at different ages. It may manifest in utero during the peripuberty area, adolescence and adulthood, and during aging. So the manifestations are different at different ages. In utero, it may have a small baby syndrome, intrauterine growth retardation, or leading to long-term health effects. In peripuberty age, say around, just before the puberty, 10 to 12 years, there will be exaggerated adrenal, increased level of androgens and insulin. There is a functional ovarian androgenism leading to precocious puberty again. In adults, it will be complete full-blown syndrome. There will be anovulation, polycystic ovaries. Obesity is very, very prominent. It's in more than 50% of the cases and also leads to reproductive disorders. In old age, say around beyond 60, there will be metabolic disorders, diabetes, dyslipidemia, There'll be a lot of hypertension, unstable blood pressure for that, not exactly hyper, maybe unstable blood pressure, which leads to metabolic effects. Next slide, Soumya. So the investigation of choice remains the pelvic ultrasound, as has been said by the previous speakers. Also, this is the mainstay of the diagnosis investigation. Transvaginal ultrasound is the best imaging modality. We should not do transabdominal because transvaginal ultrasound is the modality of choice, has been insisted by previous speakers. Also, Dr. Soumya have said that the endometrial thickness needs to be considered while evaluating the polycystic ovaries to exclude significant endometrial pathology which could have been there. Adnexes are well evaluated with the polycystic ovaries. Ovaries may be normal in polycystic ovaries during the ultrasound evaluation. The polycystic ovarian morphology may be seen in women without the syndrome also. However, it is accepted that women with PCOS tend to have large ovaries with an increased number of follicles. The updated diagnostic criteria at the time of review are based on a 2018 study. These studies are available on Google. These studies are available in various journals, but I have just compiled all those figures in patients with more than 8 years of age post-menarche and using high frequency probe, follicle number per ovary more than 20 or equal to 20. The ovarian volume equals to or more than 10 ml, ensuring no corporal lutea, cyst or dominant follicles. And if using transabdominal scanning, because if it's a female who's unmarried, ovarian morphology is not well visualized, consider using the ovarian volume threshold of more than 10 ml on either ovary. Next slide. The diagnostic criteria adjusted in adolescent females defined as within 8 years of menarche or age less than 20 years, in whom ultrasound should not be used for the diagnosis due to the high incidence of multifollicular ovaries. We might get confused because that is the time they will have the multifollicular ovaries in that stage of life. So better to avoid the overdiagnosis of polycystic ovary by differentiating between multicystic ovaries and polycystic ovaries. I'm sorry. The presence of single multifollicular ovary is sufficient to provide the sonographic criteria of PCOS. Other morphological features have been described, such as hyperechoic central stroma, peripheral location of the follicles, typically called as string of Paul sign, follicles of similar size measuring 2 to 9 mm. Histologically, on a cut section, it appears there's a subcapsular follicles in various stages of atresia. The most striking ovarian features of PCOS is hyperplasia of these theca stromal cells surrounding arrested follicles. Microscopically, luteinizing theca cells are also seen. And there is an increased size and smooth white surface reflecting the thickening of the capsule on histological evaluation. The pathophysiology is a vicious cycle. There is abnormal gonadotropin secretion, excess LH, low tonic FSH, that is follicle stimulating hormone. There is a hypersecretion of androgens, which disrupts the follicular maturation. The substrate for follicular peripheral aromatization is a negative feedback on pituitary, decreased FSH secretion, insulin resistance, and elevated insulin levels. So it's a vicious cycle. Once this goes up, this goes down. So it is a cycle, constant cycle. There are many theories of pathophysiology of autosomal dominant gene, downstream signal defect in gonadotropin receptor hormones, E2 LH insulin resistance, PCOS introgen, functional hyperandrogenism. There are many theories. Next slide. There is an international consensus definitions. These are of actually theoretical importance. If anyone wants, they are easily available. I need not read all those definitions because these are just definitions. Just to complete the list, I have included in my PPT. A woman having PCOS in absence of an ovulation disorder or hyperandrogenism, that is asymptomatic PCOD, should not be considered as having PCOD until more is known about this situation. This is very, very important because, as said by Dr. Soumya, they carry that tag, they carry that stigma with them until unless we diagnose them comfortably. Surely, let's not label them as PCOD. In addition to its role in the definition of PCOD, ultrasound is helpful to predict the fertility outcome in patients with PCOD, where the response of clomiphene citrate they need to evaluate, and also for the risk of hyperstimulation syndrome, which happens mostly in the cases of IVF or IUI, decision for in vitro maturation of oocytes. It is recognized that appearance of PCOD may be seen in women undergoing ovarian stimulation for IVF. In the absence of overt signs of PCOD, So be very cautious by labeling it to be a polycystic ovarian syndrome. Next slide, please. The following technical recommendations should be respected. State-of-the-art equipment is required. To label it, the equipment should be upgraded, operated by appropriately trained personnel. The transvaginal approach should be preferred, especially in the obese patient, because while obesity, many a times we tend to over-diagnose the PCOD. Let's be very frank about it, discuss with the patients, and we should always promote the transvaginal approach. Regularly menstruating women should be scanned in the early follicular phase. That's the time they should be scanned, day between 3 and 3+1, 3 or third or fifth day. Oligoamenorrheic women should be scanned either at random or between day 3 or 5 after a progesterone-induced bleed. If there's an evidence of a dominant follicle, that means if it is more than 10 millimeter or a corpus luteum, the scan should be repeated in the next cycle too. It is very important. As radiologists, we should be doing it because the patients come to us. It's our responsibility to guide them properly. Many a times the referring doctors may not be knowing the days when these scans should be done. So it is our duty to explain it to the patient, to explain it to the referring doctor. Calculation of ovarian volume is performed using the simplified formula for a prolate epicenoid. Now, follicle numbers should be estimated both in longitudinal, transverse, and anteroposterior cross sections of the ovaries. Follicle size should be expressed as the mean of the diameters measured in the 3 sections. The usefulness of 3D ultrasound, Doppler MRI for the definition of PCOD has not been sufficiently ascertained, so should be confined to the research studies only. So the bottom line is 2D ultrasound is definitely useful for the diagnosis of PCOD. Well, there can be some complications. If there's a disease, there has to be some complications of the disease. A lot about it, talked about it: infertility, gestational diabetes, miscarriage of premature births, non-alcoholic steatohepatitis, the metabolic syndrome of abnormally high blood sugar, abnormal cholesterol, or triglyceride levels that significantly increase the risk of cardiovascular disease. There is a very high chance of type 2 diabetes or pre-diabetes. The sleep apnea, the depression, because it's a stigma to the family, to the lady. She's very anxious and definitely leading to depression. There will be abnormal uterine bleeding, which is very common with these ladies. There could be there could be a cancer of uterine lining, endometrial cancer that we know of. Obesity is associated with PCOS and can worsen the complications of the disorder. The criteria for the metabolic syndrome in women with PCOS, there are a lot of risk factors and the cutoff which I have charted out. The abdominal obesity, waist circumference more than 88 centimeter is a criteria. Triglyceride level more than 150 milligram per deciliter. HDL-C less than 50 milligram per deciliter. Blood pressure more than 130, more than 85 millimeter. Fasting and 2-hour glucose level from OGTT. 3 out of 5 qualify for the metabolic syndrome in women with PCOD. See, PCOD treatment is not only the medical treatment. There are lifestyle adjustments and lifestyle modifications play a very important role in PCOS treatment. So treatment part is towards a gynecologist. I'm not the person to comment on the treatment part, but yes, lifestyle management plays a very important role. Nutritious diet, regular exercise, and good eating habits are very important. They really help. I've seen the patients who are coming to me for follicular treatment by just following good diet and exercise. They are really, they get pregnant with sometimes they just get pregnant with these basic things also. Of course, pharmaceutical options are available. There could be alternative medicines available in the market. There was some herbal, I'm not sure how they work on, but they really help. So the first thing first is good diet, regular exercise, because you tend to put on a lot of weight. So exercise is must. Exercise could be in any form. Next slide. Dietary changes and weight management is very important. Dietary changes means reduced intake of sugars and carbohydrates. Many women with PCOS have insulin resistance. So in that case, the body does not use the hormone insulin effectively. Insulin is, and ideal diet should include healthy carbohydrates. It's a lot of veggies, fruits, lean meat, poultry, fish, high fiber grains, especially the food which are low in glycemic index should be used. And what to avoid, each one of us know, but Just to enumerate, I will mention here that refined carbs, maida, rice, potato. We all are very fond of potatoes, but they are not really good for the ladies suffering from PCOD. And aerated drinks and juices should be completely avoided. They are absolutely no for PCOS. Regular exercise, it could be yoga, it could be skipping, it could be running or gymming or whatever suits you. If anyone wants, I can always guide for the exercise. Now, because of time constraint, I cannot demonstrate anything here. Otherwise, next time I'll definitely demonstrate some good yoga poses. Kapalbhati is very, very good. The bridge is very, very good for the patient suffering from PCOD. Surya Namaskar. The basic Surya Namaskar is absolutely helpful for PCOS correction. And nutrition will be talked about by Dr. Gomati, and I'm sure she will give us a good line about the diet also for PCOD. Next slide. The treatment plans need to be according to the goals, short-term goals, long-term goals. Short-term goals I've already enumerated. Long-term goals for pregnancy planning, if other options have failed, then is the point in treatment. Next slide. Thank you so very much for having me here. Thank you.
Thank you so much, Dr. Ritu. You covered everything. You've spoken about everything when you're speaking. And for all those who were listening, one of the things that was not mentioned possibly in her, the things when I described her was that she's a yoga expert, which everybody has understood. So I'm sure, like she told, she'll guide you in all the yoga poses. And definitely, we hear a lot of things about it, how yoga helps, how the diet helps. It is a holistic approach, basically.
It's a holistic approach. Absolutely, absolutely.
So definitely. And I just had one or two things to ask you, Dr. Ritu. I think we all overdiagnose PCOD a lot these days because
absolutely
it's being given left and right. But sometimes you come across a report where you say there's a PCOD and you still see a very nice dominant follicle sitting there. So how do you agree? Do you think that's right to be calling them as, having PCOD when they have a dominant follicle there? I think, sorry. Okay.
I can't hear.
He's not able to hear.
Oh, okay. I'm sorry. Okay, Gomati ma'am, you can come in. Anybody can come in. It's okay.
Once, if a polycystic ovarian disease is diagnosed, you have to do a continuous screening every month. And once you see a dominant follicle, if she's married, that is a dominant follicle. You can't say she was under treatment for polycystic ovarian. It is a polycystic ovary for which a treatment was given and one follicle has become dominant. That is a good sign for her.
No, I'm saying that we get reports where they say that you see a dominant follicle also, and this patient is being labeled.
Avni, I think, polycystic ovary doesn't mean that they won't have
dominant follicle.
They don't have ovulation, nothing of that sort. See, basically it is there can be a follicular defect, or there can be an ovulation defect, or there can be a combined defect. And what we mean by a follicular defect is a follicle fails to enlarge into an optimal size.
Ovulation.
And ovulation defect is that it fails to rupture. There can be a combination of both these things in polycystic ovaries. But for polycystic ovaries, the patients may be having a normal ovulation with normal follicular size development, with normal rupture of ovulation that may be happening, but the timing may not be the typical 14th day of ovulation, 14th day in a 28-day cycle. That may be a little prolonged for them. So the follicular studies will help us to time it for
to ensure that it's a rupturing.
Dominant follicle can be a normal phenomenon of a follicular enlargement in case of a polycystic ovary. But in polycystic ovaries with follicular defects may have a limitation in having a normal and optimal increase in size of a follicular thing, but that need not be there in all the cases.
And one more thing I just wanted to clarify is we most often label the thing as our reports as saying PCOD or PCOS. But actually that's an entire spectrum with the clinical thing. If we have the clinical features, yes. But many times these days we find it incidentally also. We find this PCOM morphology, that polycystic ovarian morphology. So as per the radiologist, wouldn't it be a better recommendation to use the word PCOM than PCOS or PCOD?
What is PCOM?
Polycystic ovarian morphology.
Morphology. Okay. So there can be lean PCOD. I think Ritu is here to answer that question.
But I think she's not able to listen to our discussion.
Okay, right. So the polycystic ovarian pattern can be, that morphological pattern can be there in cases like lean PCODs where the obesity and all these components need not be there. So this pattern is very common. So whether you call it as the morphology or the syndrome, polycystic ovarian syndrome, it's a different combinations. But the pattern, whether it causes a basically a follicular defect or a ovulation defect or a combination of these things, is what we are looking into, and especially when we are evaluating an infertile female.
During evaluation of infertility, definitely that thing comes in, and we understand PCOD is a very, very important factor in infertility now.
I have a question to Ritu. Ritu, when we say polycystic ovarian syndrome or morphology, whatever it is, the size of the follicle, if it is somewhere between less than 9 mm, they say it is definitely a polycystic, because if it is getting enlarged, getting dominant, it is going for ovulation, isn't it? Does a polycystic ovarian, if the follicle is less than 9 mm, how will you going to describe it? If it continuously the patient is not getting a dominant follicle.
Yeah, those are the cases where there is a follicular defect is there. The follicle fails to reach an optimal size.
Yeah.
Yeah, those are the cases of polycystic ovarian disease.
So, so you need a continuous follow-up of these patients.
Yeah. Right. Yeah.